Hello and welcome to this Informed CE Masterclass, where we aim to eliminate redundancy in drug information in order to drive evidence-based care. I'm Scott Perkins, and I will be the presenter for today's CE. If you've been with us before, you likely already know the rundown regarding how this works. But for those of you who are new to our CE, well, first, welcome. Informed has a drug information database of over 10,000 drug information requests that we've received over the years from healthcare providers really across the United States. Now, what we found is that about 40% of the time that we receive a new request, it's technically one that we've already answered previously. So as a result, we wanted to develop some continuing education programs based on some of the most popular DI requests to be proactive and answer requests that you might have before you even send them our way. That being said, if you have a specific topic you'd like for us to develop a CE around, please don't hesitate to contact Janvi at janhavi@informed.com. Today's CE was developed by 3 pharmacists. Janvi Punyarthi developed the material for today's programming. She's a director of brand management at Informed. Yutong Yang is a drug information specialist at Informed and acts as the Informed drug information liaison for developing CE. And like I said, I'm Scott Perkins. I'm a clinical associate professor at Campbell University's College of Pharmacy and Health Sciences and a co-director of drug information at my institution. And I've been an academic partner with Informed now for the past several years. Of course, it's important to note that the 3 of us have no relevant financial disclosures to make with regard to the CE program. So now that we've covered some of the relevant background, let's get into today's CE. The title for today's continuing education program is What is the effectiveness of tirzepatide for weight loss in adults with type 2 diabetes? Today's learning objectives are to identify clinical characteristics of tirzepatide, identify the importance of how tirzepatide differs from existing therapies, describe strengths and weaknesses of applicable medical literature regarding tirzepatide, recognize the positives and negatives of using tirzepatide in clinical practice, and to discuss the clinical applicability of using tirzepatide for weight loss. Tirzepatide was approved by the United States Food and Drug Administration last year on May 13, 2022, for use in patients with type 2 diabetes as adjunct therapy in order to achieve improved glycemic control and weight loss. Tirzepatide is a novel agent with a dual mechanism. It is both a glucose-dependent insulinotropic polypeptide, or GIP, and glucagon-like peptide, or GLP-1, receptor agonist. Tirzepatide is administered via a once-weekly subcutaneous injector pen and can be administered at all of the typical subcutaneous sites, the abdomen, thigh, the upper arm. Available strengths start at a low concentration of 2.5 milligrams per 0.5 milliliter and increase at 2.5 milligrams all the way to 15 milligrams per 0.5 milliliters. The recommended starting dose is the lowest available dose of 2.5 milligrams weekly for 4 weeks. This is followed by a dose increase to 5 milligrams once weekly and titrated thereafter. As I mentioned a moment ago, tirzepatide is a glucose-dependent insulinotropic polypeptide, or GIP, glucagon-like peptide, or GLP-1, receptor agonist. It has your typical GLP-1 receptor agonist effects like delaying gastric emptying, appetite suppression, and improved satiety. The delay in gastric emptying is most prominent after the first dose, but this effect does wane over time. The GIP component provides an additional benefit not noted with most GLP-1 agonists, which is the improvement in nutrient and energy metabolism. Both hormones increase insulin secretion and decrease glucagon secretion, and together These effects have a combined effect on both glycemic control as well as body weight. In addition, earlier studies indicate tirzepatide also increases insulin sensitivity and fasting glucagon concentrations by 28%, and glucagon's area under the curve by 43%. In the 2023 American Diabetes Association guidelines, the Standards of Care in Diabetes, tirzepatide has been added as an injectable option alongside other medications with activity on GLP-1 receptors as a glucose-lowering option, especially those for whom weight loss is advantageous. Now, I do think that it's important to stress when we talk about indication, tirzepatide is not currently approved by the United States Food and Drug Administration for the treatment of weight loss in patients without diabetes at this time. GLP-1 receptor agonists like liraglutide and semaglutide, they do carry this indication alongside agents like orlistat, phentermine and topiramate, naltrexone and bupropion, but tirzepatide is only approved for patients with type 2 diabetes at this time. In terms of special populations, there is currently insufficient data to determine the risk of birth defects if tirzepatide is used by pregnant women. Tirzepatide also shows up in the milk of breastfeeding mothers, but the effects on the breastfed infant are unknown. For women of childbearing age, tirzepatide may reduce the efficacy of oral contraceptives, and the manufacturer recommends that females should switch from oral contraceptives to other forms of contraception or add a barrier method for 4 weeks after initiation and 4 weeks after each dose increase. Tirzepatide carries a boxed warning for thyroid C-cell tumors, which includes medullary thyroid carcinoma, and therefore anyone with a previous history or a family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2 should not take tirzepatide. This warning comes from the dose-related, treatment-dependent thyroid C-cell tumors that have occurred in rats. The risk has not yet been established in humans. Other warnings to note are also not all that different than other GLP-1 receptor agonists, including pancreatitis, hypoglycemia, hypersensitivity, acute kidney injury, gastrointestinal disease, diabetic retinopathy, and acute gallbladder disease. The most common adverse reaction should come as no surprise if you're familiar with other agents that affect GLP-1 receptors. Patients taking tirzepatide may experience decreased appetite, nausea and diarrhea, an increase in both serum amylase and lipase. Drug interactions with tirzepatide also come as no surprise. Caution should be used with insulin and insulin secretagogues due to the potential risk for hypoglycemia. And gastric emptying can affect the absorption of hormonal contraceptives as well as narrow therapeutic index medications. As I mentioned a moment ago, it's advisable for patients using hormonal contraceptives to utilize a physical barrier during intercourse for the first 4 weeks after initiation and for the 4 weeks after each dose increase. Monitoring parameters to take note of are gastrointestinal adverse effects, kidney function, signs and symptoms of either pancreatitis or gallbladder disease, and worsening of diabetic retinopathy. Tirzepatide is available in a preservative-free injector pen that should be refrigerated, although it can be left unrefrigerated for up to 21 days if the temperature doesn't go up to above 86 degrees Fahrenheit. It should not be used, however, if it has been frozen. The average wholesale price for tirzepatide, really regardless of the dose, is $306.91 per pen. All right, now that we've learned a little bit about tirzepatide, let's take a look at the literature surrounding tirzepatide and weight loss. We will cover the major approval studies, the SURPASS studies, as well as the SURMOUNT-1 study, which was not conducted in patients with type 2 diabetes, but instead assessed weight loss potential with tirzepatide in obese patients without diabetes. The SURPASS studies focused on glycemic control in patients with type 2 diabetes, but also evaluated changes in body weight. When we cover these studies, we'll specifically focus on data regarding body weight reduction. I want to make that clear that we won't focus as much on our glycemic goals like A1C. SURPASS-1 was a randomized controlled trial that included about 500 patients with type 2 diabetes that was inadequately controlled with lifestyle alone. SURPASS-2 focused on patients with metformin doses greater than 1,500 milligrams. SURPASS-3 evaluated patients stable on metformin alone or in combination with an SGLT2 inhibitor. SURPASS-4 looked at any combination of metformin, sulfonylurea, or SGLT2 inhibitor. SURPASS-5 included patients really taking stable doses of insulin glargine. All right, so let's first take a look at the data from SURPASS-1. Remember, this study evaluated tirzepatide versus placebo. So we expect there to be a meaningful difference in weight loss. The population included in the study was limited, and it limits the external validity of the results a bit, as it really only involves patients who have diabetes who are only attempting to control it with lifestyle changes. Their A1C values also must fall within sort of the narrowest range of any of the studies we'll discuss, between 7 and 9.5. So there are some limitations in terms of external validity for this study. Patients included were generally in their early to mid-50s, which makes sense considering the inclusion criteria for this study. The mean body mass index and body weight are consistent with patients who are overweight. After 40 weeks of therapy, baseline change from weight in the tirzepatide group ranged from a reduction of 7 kilograms in the 5 milligram group to 9.5 kilograms in the 15 milligram group. Clearly, a statistical difference was noted compared to the placebo group. Of course, you would expect that. The percentage of patients achieving specific weight reductions are presented here. Researchers also looked at dichotomous variables using an odds ratio. The odds that patients achieved weight loss of greater than 5%, 10%, or 15% were significantly improved compared to placebo. It's worthwhile to note that this study suggests not all patients prescribed tirzepatide will have such large reductions in weight. Looking at the percentage of patients on tirzepatide that achieved a 5% weight loss, you'll notice that somewhere between 1 and 3 patients to 1 in 5 patients may not achieve weight reduction with this medication. This likely has to do with the modified intent to treat nature of this study, meaning that data from patients who were not compliant or dropped out still had some of their data included. So that 1 in 3 or 1 in 5 numbers don't necessarily mean that it's not working for these patients, but the patients may have elected to not take the medication or simply been lost to follow-up. In SURPASS-2, we're looking at patients who are only on metformin at the maximum or nearly maximum dose. And this time, instead of comparing to placebo, we're comparing tirzepatide to active treatment with semaglutide over a 40-week period. But don't be misled here. Semaglutide 1 milligram is neither the initial dose nor the maximum dose of semaglutide. So we can't exactly compare apples to apples here with this study. The maximum dose of semaglutide for patients with diabetes is 2 milligrams. But when purely used for weight loss, it can actually be given at doses of 2.4 milligrams. So this study gives us an idea for which doses of tirzepatide are comparable to 1 milligram of semaglutide, not that one agent is better than another. tirzepatide doses of 5, 10, and 15 milligrams reduced weight by 7.6 kilograms, 9.3 kilograms, and 11.2 kilograms, respectively. Comparatively, 1 milligram of semaglutide reduced weight by 5.7 kilograms. Each tirzepatide dose reduced weight by a statistically significant margin when compared to 1 milligram of semaglutide. Again, remember, this study cannot be used to suggest that one agent is necessarily better than another agent, but that weight reduction from 1 milligram of semaglutide is most comparable with weight reduction from about 5 milligrams of tirzepatide. SURPASS-3 was conducted in our insulin-naive patients on metformin with or without an SGLT2 inhibitor. Doses of tirzepatide were compared to insulin degludec. Now, before you say to yourself, well, of course, tirzepatide is going to decrease weight more than insulin, patients are expected to gain weight while on insulin. Just keep in mind that the primary outcome of the study was focused on glycemic targets and not weight. Regardless, weight was one of the secondary outcomes noted in the study. Since the weight-related results will come as no surprise, we'll really want to cover these for the sake of completeness, but as expected, weight reduction among the various doses were similar to our previous studies, and insulin degludec was associated with an increase in patient weight by 2.3 kilograms on average. The percentage of patients achieving a weight reduction of 5, 10, and 15% did not drastically differ from the previous studies. But it's notable that nearly 90% of patients in this study achieved a weight loss of 5% or more when on 15 milligrams of tirzepatide. We also saw the largest percentage of patients with a 15% weight reduction in these SURPASS studies we've discussed, with 43% of patients taking 15 milligrams of tirzepatide achieving this reduction. SURPASS-4 was our patient population with type 2 diabetes and established cardiovascular disease on any combination of metformin, sulfonylurea, or SGLT2 inhibitor. Patients in this population were generally older than our previous population, which is not surprising as these individuals could be on up to 3 anti-diabetic medications. In this study, tirzepatide was compared to insulin glargine, and once again, the expected weight gain with insulin glargine was noted. And we once again saw weight loss totals similar to what we've seen in the past, with tirzepatide being associated with a reduction in 7.1 kilograms, 9.5 kilograms, and 11.7 kilograms with 5, 10, and 15 milligrams respectively. In the SURPASS-5 study, researchers evaluated a patient population of individuals with type 2 diabetes who are already taking once daily insulin glargine. Once again, this is an older population since these individuals have already progressed to requiring insulin therapy. But we're hoping that the addition of tirzepatide will reduce the weight gain we expect in patients receiving insulin. At 40 weeks, tirzepatide significantly reduced weight in patients taking insulin when compared to placebo, though the reduction from baseline is not as great as the reduction seen in patients who are not taking insulin. When accounting for the weight gain seen in the placebo group, the differences between 5, 10, and 15 milligrams of tirzepatide were a little more similar to a general baseline reduction in patients not receiving insulin, and the reductions of 7.1 kilograms, 9.1 kilograms, and 10.5 kilograms seen with the doses of tirzepatide. The percentage of patients achieving weight loss targets from baseline were also diminished in comparison to studies in which patients were not receiving insulin. For instance, less than half of the patients taking tirzepatide 5 milligrams achieved a weight reduction of 5% or more. With that said, weight reduction seen was still favorable when compared to placebo. Finally, let's look at the SURMOUNT-1 study. This study did not require patients to have type 2 diabetes, but followed obese patients for 72 weeks while taking various doses of tirzepatide or placebo. Since this was a weight loss study, this time the co-primary outcomes were change in body weight from baseline to week 72 and weight reduction of greater than 5% at week 72. Additionally, it's also important to note that this study included a lifestyle intervention for both groups. On average, this population was between 10 and 15 years younger than the other populations studied, but these patients had much higher BMIs. After 72 weeks of therapy, those in the 5 milligram group experienced a mean change in body weight of 12% compared to placebo. In the 10 and 15 milligram groups, this difference was 16 and nearly 18% respectively. Now, to put this into perspective, tirzepatide and lifestyle interventions reduced weight in the 15 milligram group by 50 pounds and by more than 41 pounds over placebo with lifestyle interventions. Though, keep in mind, this population was the heaviest we've seen with a baseline weight of nearly 230 pounds. The percentage of patients achieving a weight reduction of 5% or more ranged from the mid-80s to low 90s for the various doses of tirzepatide and was 34.5% in the placebo group. Notably, this was the highest percent of weight loss observed in any of the placebo-controlled studies mentioned previously. But keep in mind, in this study, patients within both groups received a lifestyle intervention. At the maximum dose of 15 milligrams, 56.7% of patients in the tirzepatide group achieved a weight reduction of 20% or more from baseline. Now, a plateau in weight loss was identified in the 5 milligram group by week 72, and higher doses almost achieved a leveling off or plateau at the conclusion of the study as well. In looking at all of the data from all of these studies, a systematic review and meta-analysis was conducted by Karagiannis and colleagues and published in 2022. Among the findings in this analysis was the expected reduction in body weight with the use of tirzepatide, which was noted to be lower versus placebo than the studies that we evaluated. Authors concluded that a dose-dependent superiority on glycemic efficacy and body weight reduction was evident with tirzepatide versus placebo, GLP receptor agonists, and basal insulin. Tirzepatide did not increase the odds of hypoglycemia, but was associated with increased incidence of gastrointestinal adverse events. So let's take a moment to put all of this into perspective and to discuss the strengths and the limitations for the available data, as well as how we can apply this to the patients that we encounter. Some strengths of the literature include the fact that these studies were multi-centered, international trials, which increased the overall generalizability of the study results. Weight loss also appears to persist for about 72 weeks, regardless of which dose is utilized, and weight loss is evident even at the lowest doses available, meaning some patients may be able to avoid nausea and gastrointestinal side effects associated with high doses of this agent. Some limitations include that patients whose body mass index are categorized as overweight are really underrepresented, with only about 5% of patients in the SURMOUNT study being considered simply overweight as opposed to obese. Next, the SURPASS studies did not evaluate changes in weight as a primary outcome, but instead as a secondary outcome. As I mentioned earlier, head-to-head comparability to other GLP-1s has not been well established, with only a moderate dose of semaglutide having been compared to tirzepatide. In addition to this, Researchers saw a higher rate of dropout due to adverse events in all tirzepatide groups when compared to all of the other controls that we utilized. All in all, tirzepatide is the first of its kind, so it's always wise to proceed with caution instead of being blinded by optimism. But at this time, it's only been approved for glycemic and weight control in patients with type 2 diabetes and does not yet have a formal approval for weight loss outside of that population. It has not been studied in patients with a history of pancreatitis and should not be used in type 1 diabetes. Though there is no dose adjustment for renal impairment required, you should still monitor patients for renal impairment who experience severe GI effects. When initiating tirzepatide, patients should start with a dose of 2.5 milligrams every week, but they need to make sure that they increase the dose to 5 milligrams in order to achieve the benefit noted in clinical studies, as clinical data around simply using the initial dose is not really well established. For those who are interested in switching patients to this agent, there are currently no standardized dosing conversions. It's important to take note of that. Now, down the road, I expect there to be some new approvals for tirzepatide, and we'll see what new approvals the manufacturer will seek in the years to come, whether this be cardiovascular risk reduction or weight loss without regard to diabetes or something else completely. As new research becomes available, I'm sure all of us here at Informed will continue to investigate data regarding this agent going forward. All right, so that is sort of the end of our presentation portion. Now I want to get into some more active focused learning. So I've got some questions that I wanted to run through the group. And we're going to do this in a different format than most folks might be used to. So on the screen, you see a couple different steps for you to participate in this activity. And what you should be able to do is you should see something that says view options at the top of your Zoom chat. Within there, you should see a label for annotate. And then when you click on that, you'll see a stamp option. And in that stamp option, there should be a checkbox. And if you give me just a moment, I'm going to allow you to annotate. So give me just a moment. All right. Everyone should be able to annotate. So just to practice, go ahead and try to insert a check mark into one of these boxes. Right. So on the next few screens, we'll have some opportunities to practice. And when we get into some content related to the presentation, I'll have you guys, there'll be a countdown timer. So you'll see that that'll be a little bit different. When the countdown timer goes away, you'll have the opportunity to put your check marks in. Let's get on with it. These are all drawings. Okay. All right. So first, I want to see how you heard about today's presentation. From social media, informed emails, simply word of mouth? Was it through CE Impact? All right, looks like we've got variable references here, so all across the board. So that sounds good. That sounds good. Right. Clear that off. And go on to the next one. All right, so next question is, what professional or area of practice really best applies to you? I'll go ahead and select Very well. Maybe I'll select academic. We'll do that. Some folks in academia, folks in other. All right. So I'd like to have some unique pharmacists on board. So looks like we've got some unique pharmacists out there. So great. All right. So we're going to begin. And remember, with these next few, there's going to be a timer, a countdown timer. So when the timer goes away, you'll have the opportunity to select the right answer. So our first question is, what is the correct mechanism of action for tirzepatide? So is it a selective GLP-1 agonist? Is it a GIP agonist? Is it an insulin secretagogue? Or is it a dual-acting GIP and GLP-1 agonist? So I'll give you some time to think, and then I'll let you select. All right. So let's see. It's like folks are choosing D. If you can, try to remember to use the stamp function. All right. Fantastic. All righty. So our next question is, tirzepatide does not result in the following. Answer choices are increased insulin sensitivity, increased fasting glucagon concentration, delayed gastric emptying, or decreased plasma glucagon levels. What does it not result in? Right. Does it not, which does it not result in? So it actually does not result in increased glucagon. So it reduces glucagon concentrations. Right. Go to the next one. Looks like some folks are having trouble accessing the stamps. If that's you, feel free to mark however you need to on there. So which of the following is not considered a significant adverse reaction associated with tirzepatide? Acute kidney injury, acute liver injury, acute gallbladder disease, or pancreatitis? It's like we have a vote for pancreatitis. Got a vote for gallbladder disease. So I figured this one might trip some folks up. So it can result in pancreatitis, but it is not known to be associated with acute liver injury. All right. All right, what black box warning is associated with tirzepatide? Is it acute kidney injury? Is it thyroid C-cell tumors? Is it hypoglycemia or acute gallbladder disease? Again, just the boxed warning. What is the boxed warning for? Right. Looks like our you guys are educated on these GLP agents. It is thyroid C-cell tumors that we need to watch out for, similar to a lot of our other GLP-1 receptor agonists. All right, got just 3 questions after this left. So what all should be monitored when taking tirzepatide? Select all that apply. Kidney function, GI adverse reactions, symptoms of diabetic retinopathy, or signs and symptoms of liver disease. Like we got some votes for A, B, and C so far. Right, okay. So the only one that doesn't necessarily require monitoring is liver disease. So manufacturer recommends to monitor for signs and symptoms of retinopathy, GI adverse events, and kidney function. So 3 areas for this drug. All right. So 2 more questions after this one. The literature assessed which drug was not compared to tirzepatide to assess its effect on weight. Was it semaglutide, liraglutide, or insulin glargine or degludec? Which one did we not discuss? Right, yep, so we looked at semaglutide, we also looked at insulin glargine and degludec. We looked at patients specifically who are already taking glargine, and patients who were not yet on insulin were compared to people who were initially put on degludec. And also we had that comparison study with semaglutide as well, but it was just that 1 milligram strength of semaglutide. Right. Number 7, what was considered a limitation of the SURPASS-2 trial? Was it that tirzepatide was not compared to max weekly dose of semaglutide? The benefit was only seen in the low dose tirzepatide group. The sample size was small and not easily generalizable to other patient populations. Or was it that statistical tests were not powered, thus results were biased? So again, yeah, I remember SURPASS-2 was our semaglutide study, and they used 1 milligram of semaglutide. The maximum dose of semaglutide for type 2 diabetes is 2 milligrams. And even for weight loss, you can use up to 2.4. So those doses weren't compared. So making a direct comparison to semaglutide and tirzepatide is not something that we can do from that SURPASS-2 study. Can't necessarily say one is better than another. So if applied in practice, what may prevent patients from wanting to use tirzepatide? Is it A, weight loss metrics are not significant? Is that we're more likely to suffer from adverse events compared to semaglutide or insulin? Is that it requires high patient adherence, or it requires REMS or requires a REMS program? So its weight loss metrics were definitely significant, so it's not A. Well, obviously, we want patients to be adherent to it, but it is not a reason that we would avoid therapy. This is a once weekly medication, and most people everyone looks like they're right on track with it being B. There's no REMS requirement, so yeah, all of our studies showed that tirzepatide had more GI-related adverse effects compared to all the other agents, including semaglutide. So I think that that's a valuable takeaway from today's CE. So